Hello everyone. I hope you all made it home safely despite the ice. I have been personally fighting with my computer all afternoon, so hopefully this video comes out right and you can see it right. If you are having any technical difficulties, go ahead and email me. I'm sure we can figure something out. What I'm going to do is I'm actually going to do sickle cell disease as one presentation, hemophilia as one presentation, and leukemia again as its own separate presentation, just to keep the file size manageable and to make it easier to upload and view in Blackboard. So we had already started with sickle cell disease. We were watching the video at the end of this slide when we had to sort of change our plans. By all means, go back, watch the video again, review it as many times as you need. It really does an excellent job of explaining what is going on that causes the problems with sickle cell disease. This is more of a picture representation of it, if you'd rather look at this. So over here on this side of the screen with the blue, we have normal hemoglobin. And then over here on this side with the red, the sickled hemoglobin. Again, notice it's got this extra little protrusion that allows it to join up and make these big long chains of hemoglobin. That's what forces the cell into its funny shape. And it also reduces the oxygen carrying capacity of that hemoglobin. There are different types of hemoglobin. There's normal, there's sickle hemoglobin or S, then there's also C and F, which stands for fetal. So let's look at what can happen inside someone's body. Of course, if we have all normal hemoglobin, great, nothing to do with sickle cell disease. If someone actually has full sickle cell disease, that's them right here, with hemoglobin SS, 2 copies of that sickle cell gene. Way more common, though, is sickle cell trait. That's this one right here. So I have one normal copy of the gene, the A gene, and then one copy of the sickle cell gene, the S gene. So trait is AS, sickle cell disease is SS, and then there are other variations. Some people have an S gene and then a C gene. It's just another kind of hemoglobin. It's not as bad as S hemoglobin, but it's not normal either. So this is sort of in between being unaffected and having sickle cell disease. And then there's thalassemias that can get thrown into the mix. And then, like I said, hemoglobin F, standing for fetal. Some people just continue to make fetal hemoglobin all the way through their adult life. So, of course, that's going to change the picture, too. This guy down here in the corner is Ryan Clark. He played for the Pittsburgh Steelers when he was in Denver in Mile High Stadium playing a professional football game, when suddenly he had a lot of abdominal pain, passed out, and had to be rushed right to the hospital. No one had any idea what was going on. Then they realized he actually had sickle cell trait. Even though it was only trait, he only had one copy of the sickle cell gene. Being at a mile-high elevation and that stress of playing professional football was enough stress on his body that it actually triggered sickle cell disease-like symptoms. He had what's called splenic sequestration, and we'll talk about that in a few minutes. But just a reminder to you that even if you only have sickle cell trait, if you're in extreme situations, really high elevations, real extreme temperatures, oxygen deprivation, even though it's just trait, it can still trigger some of those symptoms. So how is it inherited? It is autosomal recessive. Autosomal meaning it has nothing to do with sex chromosomes. Recessive meaning you need 2 copies of the gene to have the full disease. So here we have mom and dad. Both are carriers. They only have 1 copy of that gene, so sickle cell trait for them. You can see they have a 25% chance that their child will be completely unaffected, no sickle cell genes at all. And then a 25% chance that the child will actually have the disease, 2 copies of that recessive gene. And then there's a 50% chance that their children will be carriers, again have 1 copy of the gene just like they do. Remember, this is autosomal, has nothing to do with sex chromosomes, so these children can be male or female, makes no difference, the chances are exactly the same. This should look familiar. This is very much like cystic fibrosis and that inheritance pattern. It is fairly common. In the United States, it affects about 90,000 to 100,000 Americans. You can see certain ethnic groups are at a much higher risk of inheriting sickle cell disease. And if you look at the bottom bullet point there, sickle cell trait, so just having 1 copy of the gene, occurs in about 1 in 12 Black or African Americans. So that's very common. Whenever you see that, your question to yourself should always be, why? Why is it so common? So here, let's have a look. Here's the distribution of hemoglobin S, or sickle cell disease, essentially, across the world. And here's the distribution of malaria. Hemoglobin S, malaria. Look similar? Yeah, it turns out having that sickle cell trait actually protects you against malaria. So in places like sub-Saharan Africa, where malaria is responsible for a lot of deaths, it's actually the people with sickle cell trait that survive and live long enough to pass on that sickle cell gene to their children. With cystic fibrosis, it's typhoid. How do we diagnose it? Well, we have lots of options, as you can see on the screen. It is part of the newborn test. That is, every newborn born in any state in the U.S. has this set of tests done to screen out for certain congenital diseases like sickle cell disease. So it is part of that. We know what the sickle cell gene is, so we can do genetic testing. But just knowing what your genes are doesn't tell us what your symptoms are. Remember, some people make that weird fetal hemoglobin their whole life and really wouldn't have much in the way of symptoms. So to actually tell what kind of hemoglobin your body is making, we do a test called hemoglobin electrophoresis. That's what the picture is here on the slide. There's this plate of jelly-like substance that goes into a tub of special fluid, and then we take samples from that patient of their hemoglobin and put it in the little wells, the little origin wells here. Then there's an electric current that runs from this side all the way towards this side, and it pushes these hemoglobin molecules through. Hemoglobin A travels better than hemoglobin S, and so we get separate little blotches of hemoglobin depending on what type it is. So someone with no sickle cell disease at all, their hemoglobin will look like this. Sickle cell trait, their hemoglobin will be two separate blobs, one hemoglobin A and one hemoglobin S. And someone with sickle cell disease will only have one blob, but now it's over in the hemoglobin S side. If someone has fetal hemoglobin, that will be its own separate little band. If they have that C-type hemoglobin, it'll be its own separate little band. So this is how we know exactly what kind of hemoglobin is actually in someone's body. There's a quick screen we can do too, the SickleDex screen, but it's only valid on infants older than 6 months old. That's about when most people stop making fetal hemoglobin, so that's when fetal hemoglobin will stop interfering with the test results. Basically, you take a drop of blood, put it in this special mixture. If it turns cloudy, it means you do have sickle cell disease, and if it stays clear, you are unaffected. Another really simple thing I can do is just do a CBC, or a complete blood count. People with sickle cell disease have a significantly reduced hematocrit and hemoglobin, so I can just take a look at that too. Prognosis for patients with sickle cell disease is better than it used to be, but still not wonderful. It used to be a fatal disease sometime in early to middle childhood. With treatments that we now have available, life expectancy is up into the mid-40s and 50s, but still that's a couple decades behind the national average. Each patient, of course, is going to be different, but we're going to take a look at many of the different complications, and I think you'll see how that together it will reduce life expectancy. So coming back to those cells, what's actually going on? I hope you remember the hemoglobin is making fibers, making it into funny shapes, and those funny shaped red blood cells just don't flow through blood vessels correctly. The big arteries and veins, no problem, but we're down to that capillary level. That's when these blood cells actually get stuck and occlude the vessels, and so there just is not circulation to certain areas of the body while this is happening. And that, of course, causes pain and swelling and ultimately tissue damage. Those funny shaped cells are tagged as abnormal by the body. So the macrophages, those white blood cells, travel around and eat some of them up, but the spleen, as long as the spleen is still functioning, actually filters out the rest of them. So there's this constant destruction of these abnormally shaped red blood cells, leading to chronic anemia. The anemia, in turn, triggers reticulocyte formation. Reticulocytes are immature red blood cells. We can tell the difference because they still have a nucleus in them that hasn't dissolved away yet. So if I see a lot of reticulocytes in somebody's body, I know their bone marrow is working hard to make new red blood cells. So in someone with sickle cell disease, I expect to find an elevated level of reticulocytes most of the time. The other issue here with these blocked blood vessels is that the tissue damage ultimately leads to scarring, which leads to more blockage, which leads to decreased functioning, and so we just sort of have a vicious downward cycle. Here are some pictures. You can see that not all of the cells are always sickle-shaped. In each of these pictures we have one sickle-shaped cell and then a few normal-shaped cells. Although in the picture here you can actually see maybe that one is starting to be pushed into an abnormal shape. But when they're this shape, they don't fit through capillaries correctly and they cause all kinds of blockages. They no longer carry oxygen very well either. Here in this slide you can just see the reticulocytes, that dark blue. That's the nucleus that hasn't dissolved yet. So that's how I can tell the difference looking at it under a microscope. Now, someone with sickle cell disease always has at least a few of these sickle-shaped cells floating through their body, but on a day-to-day basis, the only problem this patient is dealing with is chronic anemia. We really run into problems when a patient has what's called a crisis, and we'll look at a couple of examples of different crises. But these are the triggers that can cause them. Notice some of them, easy to avoid. High altitude, great, I can avoid that. Pregnancy, I can avoid that if I want to. Some of the other ones though, stress, infection, fatigue, it's pretty difficult to live your life without encountering those triggers. So what actually happens when one of these triggers shows up in a person's life? Well, the most common complication is called a vaso-occlusive crisis, blocking of the blood vessels, right? It can also be referred to as a pain crisis because that is the most prominent symptom for these patients. It is extremely painful. I don't know if you guys remember last semester, first semester, when you were learning to take blood pressures and you were practicing on each other. You would inflate the cuff around your classmate's arm, and then you weren't quite sure what you were doing, and you would leave it on too long, and then, the poor person with the blood pressure cuff around their arm, your arm really starts to hurt. You have a lack of blood flow to that arm. And that was just a couple of minutes. Now imagine that you have a lack of blood flow to some part of your body for days. And imagine how painful that must be. And that is exactly what's happening in a vaso-occlusive crisis. Every patient tends to have a different area of the body that is affected most often. So a patient might say, it's always my legs that are affected, or it's always my back that is affected. But really it can be any part of the body. Remember from the silly video we watched, just that inflammation causes fever, swelling. Of course, if the blockage happens in the brain or in the heart, it can cause a stroke or heart attack. The problem with the vaso-occlusive crisis is that it's sort of this vicious cycle again. Here we go with another vicious cycle. We have the patient, for whatever reason, this sickling has caused a blockage. Then there's sort of this chain reaction where the blockage is causing the release of all these inflammatory hormones and chemicals, like the cytokines, causing more inflammation, causing more sickling, which decreases the oxygen carrying capacity of the body. And of course, remember, it's the deoxygenation of these molecules that causes the problem in the first place. So then we have more sickling. So sickling just piles on top of itself, leading to severe anemia, since most of the red blood cells in the body are now no longer working. And of course, very low oxygen levels as well. Pain is the most prominent symptom, though. Patients will experience the pain for hours or days before those other symptoms all start to pile up. So this is our treatment priority. We really want to make sure that we are not just treating breakthrough pain, but really managing and preventing that pain in the first place. So we will do IV analgesics initially, both some kind of anti-inflammatory, maybe ketorolac, which is also known as Toradol, and then on top of that some kind of opioid, morphine or Dilaudid or fentanyl or something like that. If the patient is able to use a patient-controlled analgesic machine, great, we'll use that. Even if they're not very familiar with how the machine works, maybe it's a small child, we can still use a nurse-controlled analgesia. It allows us to give a basal rate of that opioid without having to go in every hour or two to administer the medication. Once the patient starts to feel better, we will transition to oral meds, but we still stay on top of it, still around the clock. Those anti-inflammatory medications, the NSAIDs, actually help break that vicious cycle of that vascular congestion. So if we continue with the NSAIDs for days or weeks, it helps prevent any kind of recurrence of those symptoms. Some patients find heat therapy very useful. It kind of helps dilate the blood vessels and improve circulation. Other patients like a little bit of gentle massage. Certainly not deep tissue or Swedish massage or anything like that. Just gentle stroking can be helpful. And then, of course, distraction works wonders with kids. So TV, video games, having friends and family visit are all very useful. There is an issue we run into with pain control for patients with sickle cell disease, though. Because they frequently experience these pain crises, they have a lot of experience with pain medications, and they begin to become familiar with the names and even the doses of the medications they need. So they might come to the emergency room and say, I have my pain level at a 10 out of 10, and I need 6 milligrams of IV morphine. To a responsible emergency room nurse, the patient being able to name the medication and the dose is a red flag of some kind of abuse or dependence on that medication. So there's definitely a balance here in sickle cell disease between adequately treating a patient's pain and making sure you're not feeding into any kind of addiction tendencies here. So what can you do? Well, you just have to use good nursing judgment. The good news is you do start to get to know your patients too if you work in one hospital long enough. And so you do get a feel for who's being more responsible with the pain medication and who might be asking for a little bit too much. Other things we do for a pain crisis. Remember that things like dehydration and lack of oxygen were triggers for further sickling, so we're going to make sure that doesn't happen. Nice aggressive IV hydration. Oxygen, even if the patient's oxygen level drops below 95, that's too low. So we'll go ahead and use oxygen for them. If the patient is so severely anemic that they're experiencing symptoms, we're worried about eventually death for this patient, we will go ahead and do some packed red blood cell transfusion. Although if it's a more mild crisis and the patient is tolerating the anemia, then we will hold off just to minimize the number of transfusions they have to have in one lifetime. With corticosteroids, we know that they are excellent anti-inflammatory medications. The problem is, as soon as we stop giving the steroid to the patient, all those symptoms come right back. So again, if someone is actually in a life-threatening situation, sure, I might go ahead and use them to sort of get through the crisis, but then I know that I'll have further symptoms to manage. So again, if it's a more mild crisis, I'll just hold off and not actually use the steroids. Another emergency we might see is splenic sequestration. And this is where that NFL football player, Ryan Clark, comes back into the story. What happens is the sickling blockage, the vaso occlusion, happens in the spleen. So the patient's entire blood supply essentially ends up in their spleen. It's not getting to the brain, it's not getting into the heart. The patient goes into shock. And the spleen becomes huge, very enlarged, and very fragile. So even just bumping that patient can rupture the spleen, and then of course they would be bleeding out. So if splenic sequestration does happen, it's an emergency. That patient needs to go immediately to surgery, and they will have their spleen removed, and then receive a lot of blood donation to restore that blood volume for the patient. With true sickle cell disease, 2 copies of that S gene, we see this far more commonly in young children simply because they still have a spleen. Essentially, if you have not lost your spleen by the time you're 4 years old to surgery, then it has turned into a lump of scar tissue, and we'll talk about that again in a few minutes. With the football player, because he only had trait, he had not been having the symptoms for most of his life. That's how he managed to survive into his 20s. with a spleen. But for true sickle cell disease, you will lose your spleen one way or the other by the time you're about 4 or 5 years old. So splenic sequestration is usually seen in those young children. Some other acute complications we need to look out for. We talked about stroke and heart attack or myocardial infarction. Take a look at the stats there for stroke. About a quarter of adults have had an obvious stroke by age 45. So think, changes in face, arms, speech, act fast, right? Those symptoms. About a quarter of children have had a silent stroke. This is where the stroke does not affect the same regions of the brain, but maybe the frontal lobe where learning and reasoning happen. So rather than having any issues with speaking or moving, the child just has issues with learning and maybe is doing poorly in school. We can only pick up on those silent strokes with MRI, which we're starting to realize needs to be a much more prominent part of monitoring for these kids. And we'll talk more about those strokes in a few minutes. We said heart attack. Acute chest syndrome is where the blockage of blood happens in the lungs. So the lungs are filling up with blood, not able to breathe adequately. We have lack of oxygenation, and there we go again with that vicious cycle of sickling cells and extreme anemia. Aplastic crisis is when the bone marrow is not able to keep up with manufacturing all those new red blood cells that are needed every day. So essentially the bone marrow gives up for a period of time. Again, we're going to see severe anemia with this. The patient will require blood transfusions. The good news is it is usually temporary, and eventually, after we get through the crisis, the patient's bone marrow kicks back in again, and we're back to seeing plenty of reticulocytes, plenty of those nice new little red blood cells floating through the bloodstream. Infection is an issue related to those spleens, and so we'll come back to that in a minute. Here are the chronic manifestations we see with sickle cell disease. I already mentioned this, but with the chronic breakdown of those misshapen red blood cells, we see anemia. A normal hemoglobin level for a patient with sickle cell disease is usually around 7 or 8, instead of the 12 to 17 range that we see with unaffected patients. Of course, that chronic anemia is going to lead to delayed growth and development for our pediatric patients, and then just some general fatigue and pallor for any of our patients. If the liver is the location of these chronic blockages for our patient, we might see jaundice, hepatobiliary disease. A lot of patients will lose their gallbladder. If it's in the eyes, we'll actually see eye disease, retinopathy, associated with this sickle cell vaso-occlusive crises. The other disease we frequently see in association with sickle cell disease is reactive airway disease, or asthma and related conditions. There's still debate going on about whether the sickle cell disease causes the asthma, or maybe there's another genetic trait that causes both of them that we just haven't found yet. But in any case, don't be surprised if you see your sickle cell patients being treated with albuterol fairly frequently. Lastly, here we have asplenia. Just translate it right, no spleen. You're missing your spleen. We talked about why your spleen might be surgically removed if you experience splenic sequestration. But now let's talk about the other reason you might lack a spleen. Here we have functional asplenia. Basically, all the buildup of those misshapen red blood cells in your spleen leads to fibrosis, or it turns into scar tissue. So instead of being a true functioning spleen, these patients just kind of have a lump of scar tissue in its place. And that usually occurs by about age 4 for our patients with sickle cell disease. In addition to filtering out misshapen red blood cells, the spleen is also responsible for filtering serious bacterial infections. So not having a spleen, either surgically or functionally, leads to this decreased ability to fight those serious bacterial infections. For little kids who have not yet had all of their immunizations, we actually treat with a daily dose of antibiotics, either penicillin or amoxicillin. It's just a small dose, but it gives them that added boost of immunity. We're also really careful with any fever that shows up, no matter how old our patient is. Rather than saying, take some Tylenol, call me in the morning, anyone with a fever and sickle cell disease needs to go either to the doctor's office or to the emergency department to be evaluated. And then, of course, vaccines are a priority. For those little kids, we're not delaying any vaccines. We really want to teach parents that these vaccines might save their child's life, and so we do work hard to get all vaccines on schedule for these children. Once a child is fully immunized, then we routinely discontinue those daily antibiotics. Essentially, the point is that every system of your body is affected. I have the little what else question there, just in case I forgot something. But just like with diabetes, if it has a blood vessel, it's going to be affected. And so after decades of dealing with sickle cell disease, you start to have chronic malfunctioning of various systems in the body, and that's why we see the shortened life expectancy. So what can I do about it? How can we prevent these issues? Well, if you flip back to that slide about triggers, you can try to avoid the triggers. I had a patient in the hospital who we saw her about once a month with these pain crises while she was going through adolescence, and she decided that was enough of that. She didn't want to keep coming to see us. And the only change she needed to make to her lifestyle was to make sure she stayed really well hydrated. She just started carrying a water bottle around with her during the day and drinking as much water as she could. And that did the trick for her. Other patients, it might be a different trigger that might be more difficult to avoid. Certainly, a woman who wants to have children will have to find some way of getting through pregnancy. Some people avoid flying, avoid living at high altitudes. So however we can avoid those triggers, that's step one. We also need to supplement these patients with daily iron and folic acid because they have to be continually making so many new red blood cells. We need to make sure they have the nutrition available to do that. A new medication that has been developed in the past couple of decades is called hydroxyurea. Basically, it decreases the production of abnormal blood cells and increases the production of that fetal hemoglobin. The fetal hemoglobin, unlike the sickle cell hemoglobin, still works just as well. It's just not what we normally see in adult humans. So we can really decrease a lot of the symptoms associated with sickle cell disease. It does have some significant side effects, though. Notice the first one on the list there is bone marrow suppression. If it doesn't work correctly in your body, rather than increasing fetal hemoglobin production, I might see that it actually decreases production of all types of blood cells, including white blood cells and platelets. So of course I would need to discontinue therapy at that time. The other patients who have difficulty taking this medication are pediatric patients. So far, it's only formulated for adults, adult-sized doses. So if I want to give it to a child who's not large enough for the adult dose, I'm either trying to break pills in half or have the pharmacist actually powder it up and make it into a liquid suspension for me. In either of those scenarios, it's really hard to get an accurate dose, and so it's not commonly used for kids, but you might see it. Something we have started to investigate, for children especially, but also adults, is monthly exchange transfusions. The patients come in once a month. We take out their diseased red blood cells and put in someone else's red blood cells, someone who's donated that blood to them. This, we know for sure, reduces the incidence of those silent strokes I was telling you happen for children. But of course, it's also going to reduce all of the other symptoms associated with the disease. So here you go. Here's the video of the young lady who is actually on the protocol.
When the other kids used to go outside and play, I would try to do that. Then I come home and very sick and have to be back in the hospital.
17-year-old Alexandria Young of St. Louis, Missouri, has sickle cell anemia, among 72,000 Americans with the disease.
Among all Americans, approximately 1 in 1,500 to 1 in 2,000 newborns will be diagnosed with sickle cell disease.
In people with sickle cell disease, their red blood cells become deformed, turning sickle-shaped. The bone marrow tries to make more red cells to make up for the loss, but can't keep up, causing anemia. Their new shape keeps them from moving properly through the body, and the misshapen cells can jam up, and stick to the walls of the blood vessels. These clumps cut off oxygen to healthy tissue, delaying a child's normal growth and causing fatigue and extreme pain.
It's like a hammer beating at you like for a long time.
I never heard anybody scream that high and just wail out, and we were like, what's wrong, what's wrong? And man, she would have it so bad where her eyes just roll back up, just roll back, and she's just in pain, just screaming, yelling, and we didn't know what to do.
And I thought she was just talking in her sleep or something, but she had mentioned that she was ready to go home. And I said, Alexandria, you are home. We're home now. She said, no, Mommy, I want to go to heaven. That's my home. And
Okay, deep breath.
Dr. Michael DeBaun has been Alexandria's hematologist since she was 4 years old.
Any headaches, double vision?
Fatigue and pain are not the only issue in sickle cell disease. Essentially, every organ in the body can be damaged by the lack of oxygen. The kidneys, the heart, the eyes, and now we know even the brain.
In addition to pain, probably the most feared complication is that of a stroke.
And right here is her silent stroke.
When Alexandria was 12 years old, a brain scan revealed that she had indeed had a stroke.
I was very scared because I thought only older people would have a stroke and not 12-year-old.
Silent strokes like Alexandria's were not even recognized until a small research study in the 90s was conducted to better understand sickle cell disease in children. MRIs showed that strokes occurred when the misshapen cells got stuck in the brain and cut off oxygen to it.
Certain locations of the brain control your movement. They control your motor ability, okay? There are other areas of the brain that if we removed it, it wouldn't alter your movement at all. It would alter your ability to think. The area of the brain in the frontal lobe is the area of the brain that's more likely to have silent strokes. So most of the children with silent strokes, they're actually walking around, interacting with their family in a fashion that makes people think that, yeah, this child is doing well.
Dr. DeBaun has Alexandria on a research protocol, hoping to stop the strokes. Monthly blood transfusions, called apheresis, remove Alexandria's damaged red sickle cells and replace them with red blood cells from a healthy donor. The hope is that the healthy new red blood cells will prevent her from having future strokes. Dr. DeBaun monitors Alexandria's condition closely, including annual brain scans to look for further damage.
I pray constantly, about Alexandria, that she hasn't had another silent stroke.
The young family won't know the results until their next visit to Dr. DeBaun.
How's the clinic?
Good, straight A's.
Straight A's?
Staying on this protocol, it has dramatically improved her classroom performance, dramatically just improved everything. Everything in her life is just completely turned around.
Whew, it's just like a switch, man. It just totally changed her. She started to grow.
Congratulations. That's fantastic. Straight A's.
How was the test results?
We had the MRI of her brain performed a couple of days ago.
It's to make sure that she hasn't had any new episodes of silent strokes.
That's right. And the answer is no. There's been no evidence of progression. So it's all done, and it's really good news. Okay?
So there you go. That was a young lady on a research protocol with exchange transfusions. You can see it worked wonders for her. Of course, that is pretty invasive, so not every patient uses that. For example, patients who do well on hydroxyurea, we'll probably leave them there rather than exchange transfusions. But that is something you might start to see more of, so keep your eyes open. Currently it's just being researched, but if it works wonders, we might start to just use it as standard of care for these patients. Alright, I'm going to end sickle cell disease here, and you can now move on to the next video for hemophilia.